Good morning, good afternoon, good evening, wherever you are. Welcome, and it's wonderful to have you all join us for this second day in our mini webinar series. So yesterday we heard about the broad picture of infectious disease modeling and decision making in the context of the global response to COVID-19. And today's an opportunity to take a deeper dive into the tools that are being used, as well as the country level analyses from modelers really working at the forefront of these efforts. So for the benefit of those who weren't with us yesterday, just a brief introduction. My name is Nim Arinaminpathy. I'm on the faculty at Imperial College London. I'm a mathematical epidemiologist there. I will be the facilitator for discussions for today's webinar. I also wanted to take the opportunity to thank Natsuko Ime, Juan Vesga and Sabine van Elsland for their incredible efforts behind the scenes to make sure that everything comes together and runs very smoothly. Before coming to talk about the details for today's webinar, I'd just like to speak very briefly about the short course in mathematical modelling that we conduct each year at Imperial College London. This is in fact some bit of important background for the webinars that we actually have today. So here's a flyer that we actually started designing towards the beginning of this year. And at that time we had great ambitions of holding this course in September of this year, but unfortunately because of the current circumstances, this has had to be postponed to September 2021. But this is the reason we're actually having these webinars actually right now, and this is in place of the intended timing of the short course. But please do keep your eyes peeled for the short course announcement next year. This is a 2-week residential course that takes place in London at Imperial College itself, and participants basically are taught by a variety of faculty, including some of the members, the speakers that we heard from yesterday. And the course itself is intended for public health professionals who are interested in learning the basics of mathematical modeling. And you don't need to have an advanced knowledge of mathematics. The course is very designed to become, if you like, accessible for individuals who don't have a recent background in advanced mathematical modeling. And also just to note, this is a course where we have at least one scholarship each year for colleagues to attend from low and middle income countries. And so we do encourage you, all colleagues who'd be interested in learning more about this, to keep your eyes peeled for the announcement for this time next year. But coming back to the webinar, for today, we're really excited to bring to you three modelers who've been working really at the forefront of some of the COVID-19 responses. And what we'll do today in the webinar session is basically have a series of talks from each of our speakers. These will be roughly 15 or 20 minutes, and each talk will be followed by perhaps a couple of minutes for 1 or 2 questions. And then once all speakers have completed, then we'll open the floor to questions from the audience, from any of the speakers. And for members of the audience, I'd like you to look at the screen. I think it's perhaps around the top right of your screen. You'll see a button that looks like 2 speech bubbles with a question mark in them. And if you click that button, you'll be able to type questions for the speakers. And we encourage you to send questions through. You're able to do so at any point in the webinar. But we do encourage questions to come through and also to help drive the discussion. Great, so let's begin. So our first speaker today is Dr. Anne Cori, who's a lecturer in the School of Public Health and the Department of Infectious Disease Epidemiology at Imperial College London. So Anne developed statistical methods and tools for the analysis of epidemic data. And she's particularly interested in emerging infections, but also those particularly challenging situations where, for emerging infections, where data is scarce and statistical methods can be developed to overcome the challenges of data scarcity in order to address important public health questions. So her research mainly focuses on viruses including Ebola, MERS coronavirus, influenza, and HIV. And I'm sure many of the audience may have used or may have come across a publicly available package called Epistim. And this is a tool for estimating time-varying instantaneous reproduction number during epidemics. And it's been used across the world to estimate the reproduction number for COVID-19. And so Anne is actually the author and architect of this tool. And so today she'll be sharing some insights with us on the complexities of estimating the reproduction number under different settings. So Anne, over to you.
Thank you very much for the introduction, Nim, and thank you for the invitation to come and speak. So as Nim said, today I'm going to talk about the reproduction number R, and I'm sure many of you will have heard about this number because it's been used across the world by governments to monitor the epidemic and to trigger the start or the stop of control measures. So today I'm going to try and give you a quick overview of what the reproduction number is, how we can estimate it, and also issues around how to interpret it. Sorry. Here we go. So the reproduction number R is defined as the average number of secondary cases generated by an index case. So if you look at the schematic here, I've assumed a reproduction number of 2, and I start with 1 infectious individual. So at the second generation, this case infects 2 new people. At the third generation, you therefore have 4 new infectious cases, etc., etc. So you see with this reproduction number of 2, you've got a very rapid typical exponential increase in the number of cases over time. And the reproduction number is a very important characteristic of an epidemic because, or of a pathogen, because it tells you that an epidemic is possible only if the reproduction number is larger than 1. So this is why, really the basics of why we want to know the reproduction number. Another issue which is important is that the larger values of the reproduction number mean that you should expect more cases eventually, and that you'll have to have more intense control efforts to be able to eliminate the disease. However, the reproduction number can change over time. It can change mainly for 2 reasons, because of saturation, and I'm going to explain what I mean in a second, and also because transmissibility of a pathogen can change through time. So here in the graphic, I'm showing what I mean by saturation. So if you have a population size that's finite, and whatever population you're looking at, even if it's very big, it is finite. After a while, you won't be able to infect any more people. And that's pictured here in the right-hand side figure, where you have 4 cases that should have appeared in an infinite population, but they don't get infected because they don't exist. So this is what is called saturation, and it means that naturally, after a while in a finite population size, your incidence is going to be lower than what you would expect under the exponential growth, and so the reproduction number will actually decrease because of saturation. So because of this saturation effect and because of changes in transmissibility, it's important to continuously monitor what the reproduction number is, because it can change all the time. Early on in an epidemic, in a large population with no immunity, we call this the basic reproduction number, R0. But really, in an ongoing epidemic, in practice, we're often more interested in time-varying reproduction numbers. So we often look at what we call the case reproduction number, or RC, and it's defined as the average number of secondary cases that an infected individual will generate, but this infected individual is infected at time t. So for someone infected at time t, on average, how many secondary cases are they going to generate? So let's have a look at what happens to this case reproduction number when transmissibility changes over time. And I'm going to take a very simple example where a perfect intervention is put in place at a given time t. So you have your regular transmissibility before, that's my red area here, and then at the perfect intervention, and therefore a 0 transmissibility time period in green here. Assume you start with 1 case, and with a reproduction number of 2, this case will infect 2 individuals, so he or she has a case reproduction number of 2. The top light blue person from the second generation, they will also infect 2 people and have a case reproduction number of 2. However, the bottom light blue person will only generate one secondary case, and that's because the second person they should have infected would have been infected in that 0 transmissibility period, so they don't make this secondary case. So the case reproduction number of the bottom light blue person is only 1. And similarly, those green cases from the 3rd generation don't generate any secondary cases because all their secondary cases should have happened in their the post-intervention or 0 transmissibility period. So they have case reproduction number of 0. So what you see here is that transmissibility decreases instantly at the intervention. You go straight away from regular to 0 transmissibility, but the case reproduction number actually decreases smoothly. It starts at 2 for the 1st generation, stays at 2 here, but then decreases to 1 for the bottom blue case, and then goes on to be 0. So it decreases smoothly, not instantaneously as transmissibility. Also, kind of weirdly, transmissibility decreases at time t, but you see the case reproduction number starts decreasing before the intervention even happens. And that's because the case reproduction number for a given individual depends on transmissibility in the future. So in summary, the case reproduction number is not necessarily a great measure of instantaneous transmissibility. So this is why we often would rather look at what we call the instantaneous reproduction number. And this is defined as the average number of secondary cases generated by an index case who's infected at time t, but if transmissibility would remain the same as it is at time t. So we assume that in the future nothing changes, everything stays as at time t, and we wonder how many secondary cases a person would generate. So here you can see in my similar example as before, all these cases on the red or the left-hand side, they had various case reproduction numbers, but the instantaneous reproduction number during all that period is always 2, and then it's always 0 after the intervention. So this instantaneous reproduction number really tells you, is the epidemic currently going up? And that's if the instantaneous reproduction number is larger than 1, or is it going down, and how sharply? And importantly, it really tells you whether your current control measures are being effective. So this is really what you want to track if you want to look at effectiveness of interventions in an ongoing epidemic. So the instantaneous R, or RI, I'll often say, is useful for real-time monitoring of transmissibility during an epidemic. So let's have a look at how we can estimate it empirically from epidemiological data. And I'm going to start by a very simple illustration. Basically, you can estimate the instantaneous R using 2 things: data on incidence over time, so the number of new cases over time, and the generation time distribution. So the generation time is the time between infection of a case and infection of their infector. So it tells you how long it takes for one generation of cases. Now, if you look at the graphic, it's pictured an incidence curve here in black. And what this says is that if you know how long it takes for one generation to happen, and you count how many individuals you have at the end of the generation, so here you have 5 incident cases, you look back 1 generation ago, you only had 1 infected individual, therefore your reproduction number must be 5. This is a very simplistic overview, but really is what we're doing when we're trying to estimate the instantaneous reproduction number. So a bit of a more mathematical description of the exact same thing. We estimate the instantaneous reproduction number, and Nim has mentioned this has been implemented in a package called EpiEstim, which is available in the R statistical software, but also in Excel. And we also have a web-based interface so that you don't have to actually install R on your computer to do this. So in this package, we estimate the instantaneous reproduction number as the ratio of the number of new infections occurring at time t, where you want to measure transmissibility, divided by the total available infectiousness at time t. So what I mean by total available infectiousness is how many cases are there from the past that could generate those new infections, and how infectious are they still. So it's the number of infected individuals from the past weighted by their relative infectiousness at time t. And the relative infectiousness over time we can measure by the distribution of the generation time that I mentioned just before. So let's take a very simple example so you understand what's behind this mathematical formula. Imagine you have a very simple epidemic ongoing. It's pictured on the left here. So 1 incident case on day 1, 2 on day 3, and 1 on day 5. And a study has estimated the generation time distribution or the relative infectivity over time after infection, and it's pictured on the right-hand side. So this tells you that 20% of your infectivity happens on day 1, 50% on day 2 after infection, etc. So the question we're interested in here in my example is, what is the instantaneous R on day 5? So on day 5, we have 1 new case, and who is available to infect this person, or who may have infected this person. It could be the case which I call case number 1, infected on day 1, and this person only has 10% of their infectivity left because they were infected 4 days ago. Or it could be any of case 2 and case 3, the people who appeared on day 3, and they have 50% respectively of their infectivity left because they are 2 days after infection on day 5. So overall, we compute the instantaneous reproduction number as number of new cases, this is 1, and number of cases that could have generated these new infections, this is 10% plus 50% plus 50%. So in my example, we get an instantaneous reproduction number of 0.91. This is a very simple example, but just to illustrate what the method is doing, really. Now, as you see, it's rather simple, but particularly during the COVID epidemic, it's become clear that there are quite common issues that people are facing when estimating and trying to interpret the estimates of the instantaneous reproduction number. So I'll try and go through some of those issues. The first one is the temporal and spatial resolution for...
Can hear you. Go ahead. Okay,
I'm so sorry about this. So I was just saying that you can't apply this method if the time step of observations is too large. So in my example, if the incidents had been recorded weekly, for example, you wouldn't have been able to do this. Sorry. Another issue is what time step you should use for estimating the reproduction number. So should you estimate daily, weekly, monthly reproduction numbers? And you can see here an example where for the same data set, the reproduction number has been estimated daily on the left-hand side and weekly on the right-hand side. And you can see that short time windows on the left will lead to highly variable estimates over time, which are very hard to interpret. So longer time windows may be preferable, but then you may actually over-smooth or over-fit the reproduction number. So you need to be careful what time window you use. And finally, spatial scale for analysis is very important. Often we estimate the reproduction number at whatever time scale is dictated by the, spatial scale that's dictated by your surveillance system. So you'll use, the city or the country or the county where you surveillance is performed. But ideally what you want to do is use a spatial scale for which you're able to disentangle locally infected individuals from individuals who are cases imported from somewhere else. And this is a nice example on the right-hand side for COVID, where the dark orange cases were identified as being ones with travel history to Wuhan, and so early on were estimated to be imported cases. And in the latest version of EpiEstim, you can actually use this information about imported cases to estimate the reproduction number. Another issue is that actually you never observe the incidence of infection or the times of infection. You never know when a person was infected. And similarly, you rarely observe generation times, so the time between infection in a case and infection of their infector. Typically, what you will use, observe and therefore use instead is the incidence of symptoms and what we call the serial interval. So that is the delay between symptoms in an individual or a case and symptoms in their infector. And This is fine to do, but you need to bear in mind that when you do this and apply the method to a time series of incidence of symptoms, your instantaneous reproduction number estimates for time t in fact reflect transmissibility an incubation ago, because cases were actually infected an incubation before they show symptoms. Some methods have been developed to actually reconstruct the incidence of infection from the observed incidence of symptoms and the knowledge of what the incubation period looks like. And this actually may be better to apply first and then estimate the reproduction number on the incidence of infection. Another issue that's very common is delays in reporting. So when a person becomes symptomatic, they're not reported as a case straight away, there's a delay. And because of those delays, you'll typically have an underestimation of the reproduction number in real time. So this is what I've tried to illustrate in this very simple graphic, where the two gray cases at the top have had symptoms already, but they've not yet been reported in the surveillance system. So what you observe, which is the black incidence curve, is actually not the full picture and will lead you to underestimate the reproduction number in the recent past. Here is an example where the authors have estimated the delay from symptoms to reporting for COVID, and at the top you can see on average it's about 6 days. And in the bottom graph you can see what this means for the incidence curve. So the observations are in blue and the adjusted incidence to account for those delays in reporting is in red with confidence intervals, and you can see the effect I was illustrating towards the recent past. Reporting can also change over time, and this will lead to problems with estimating the reproduction number. So it's worth noting that the method I've described to estimate the reproduction number will give you unbiased estimates of the reproduction number, even if you only see a fraction of the cases, but this fraction has to be constant over time. If there is changes in reporting over time, then you will have biased estimated reproduction numbers. So this can be the case early on, for example, typically when you're unaware of a new epidemic, so your reporting system is not yet in place, and suddenly, as you become aware, your reporting system becomes much better, so you'll see a steep increase in the case numbers, not necessarily because the reproduction number has increased, but just because your reporting has become better. So the example here shows you in blue the observed cases for Wuhan, with a case definition for COVID that has changed over time, and in grey the reconstructed full picture of the whole incidence. And you can see that in recent days we estimate that the observed incidence is pretty close to the whole incidence, but early on we're only seeing a very small fraction of cases. So such changes in case definitions may affect your estimates of the reproduction number and should be accounted for. Uncertainty in the serial interval or the generation time distribution is also something that you need to be aware of and account for. In the picture here, you can see that assuming a short serial interval will lead to much lower reproduction number estimates than if you assume a long serial interval. And at the bottom, you see estimates of the serial interval for COVID, and you can see that across studies there is a lot of variability, but also within a study there is large uncertainty as to what the serial interval could be. So this is something that you need to account for, and again, EpiEstim allows you to account for this whole uncertainty or variability within your framework to estimate the reproduction number. A study has demonstrated that for COVID, but it could be the case for many other pathogens, the serial interval has actually decreased over the epidemic as non-pharmaceutical interventions were put in place. So typically, for example, with isolation of cases, what you do is you truncate the tail of the serial interval because you no longer allow secondary cases later in the course of infection. So this leads to a decrease in the serial interval that's pictured at the top. And you can see how not accounting for such a change in the serial interval when estimating the reproduction number may affect your reproduction number estimates. So at the bottom, you have in red a more sophisticated method for estimating the reproduction number, which accounts for the decrease in the serial interval. And in grey, you have the epi-estim type estimates, which use a long serial interval as seen in the early epidemic, that's on the left, and all the way to the right is using a shorter serial interval as seen later in the epidemic. So you can see how this will also affect your estimates of R. Now, aside from all the biases that I've mentioned, the reproduction number can change because of a very large number of reasons. It can change because you have a change in the proportion of susceptibles. So if you suddenly vaccinate, for example, a fraction of the population, it can change because of changes in behaviors, because of interventions, but also because of changes in environmental conditions or mutations, for example. And most likely, a reproduction number will vary because of a combination of a number of those reasons. And quantifying the contribution of the different factors to changes in the reproduction number is very hard. And to do this, you need a lot of data. So you need serological data, you need behavioral data, quantitative behavioral data. You need data on interventions, that's again quantitative, and that is sometimes pretty hard to retrieve. You also need non-aggregated epi data to understand more about the transmission. And often you will have to do some modeling, and maybe we'll hear about this from other speakers, to be able to disentangle the different contributors to differences in reproduction numbers. So in conclusion, the reproduction number has multiple definitions. The instantaneous R is the most useful, arguably, for real-time monitoring of an epidemic, and there are tools, including epi-estim, to estimate it. But as you've seen, there are many uncertainties and practical issues when doing this, and you really need to be cautious when interpreting a change in the reproduction number, and in particular, a decrease in the reproduction number. I'll encourage you to read the preprint by Gostick et al. That goes through a number of those uncertainties and practical issues. And finally, I focused here on one method, mainly epi-estim, which is an empirical method to estimate the instantaneous reproduction number, but there are many other methods that you can use to estimate the reproduction number that I haven't had time to cover. And to finish, I just wanted to say the reproduction number is a very important parameter, but it really doesn't tell you everything. So very different epidemics could have the same reproduction number. So as much useful as it is to sort of monitor the big picture of where you're at and whether you're doing enough to control an epidemic, it's really important to understand through epidemiological studies what's behind those numbers, really. Now, thank you for your attention. Really sorry about the technical issues, and I'll be happy to take questions if we have time. Thank you.
Great. Thank you so much, Anne. And I'm sure it is a very helpful sort of overview of this widely available tool, but also some of the background information that will be helpful for people using this tool to be able to use it most effectively. Thank you so much. So we're getting some comments rolling in from the audience, thanks to folks who have posted already, and I do encourage people to keep the questions rolling in, please. So there are a couple of interesting points that have been raised. One is around asymptomatic cases, which we know is one of the characteristic features of SARS-CoV-2 infection. So the question here is, asymptomatic cases, many of them will go undetected. So in that case, isn't the on estimates of the effective reproduction number, could they be misleading? Perhaps this relates a bit to the point that you made about detection earlier. Yeah.
Yeah, sure. So yeah, this is a very important point. So as I said, actually the method I presented is robust to underreporting. So if it's constant over time. So let's say you have half of your cases that go undetected because they're asymptomatic or for any other reason. As long as this is constant over time, it won't affect your estimate. If you think about my schematic where you see one case in the first generation and then 5 in the second, and you derive from this that the reproduction number is 5, If you had 2 in the first generation and then 10 in the second because you miss half and half, then you would still get a ratio of 5. So basically, this is not a problem, again, as long as it's constant over time. If it's not, then you need to correct for changes in reporting over time.
Fantastic, thank you. And one more question, again, anonymously posted, but this is this interesting observation that in many country settings, testing early on in the epidemic might have been limited to hospitals and severe acute respiratory illness. And then testing practice might actually expand as the epidemic progresses, and you might actually be taking into account less severe illness as well. And so could you speak to how that might bias these sorts of estimates, and what if there are things we can do to try and counteract that bias?
Yes, sure. So I think I showed an example of the changing definition of the COVID for the Wuhan epidemic. I think this is work from Ben Cowling and colleagues, and what they've tried to do is reconstruct statistically what they think is the full epidemic curve based on a case definition that has changed over time. So if you were to do this in real time and then estimate your reproduction number based on the inferred true incidence curve, then you shouldn't have any issues. Of course, this is quite hard to do because, in real time, I'm not sure how easy it is to do this. So yeah, basically you can statistically correct for changes in reporting over time if you know how reporting has changed. Now, another issue that was raised in the same question is that the types of cases you detect over time might be different. So it's not only the difference in the numbers or the proportion that you see, but also the fact that you see more or less symptomatic or severe cases. And I think then you need to go into more details about how relatively infectious these cases are. So are severe cases more infectious than others? And I think once you start doing this, you really sort of need a more complex model. So this is why I was saying this tool, and this number, the reproduction number, is really just showing you a whole picture, but it doesn't, or sort of generic picture, but it doesn't tell you what's behind it. And I think it's useful because it's very generic, so it can be applied, and it's been proved during this epidemic for any new pathogen very easily. But again, it has to be probably tweaked for more detailed specific cases. And that's, something that other researchers have been doing. And I've been really glad to see this.
Fantastic. Thank you so much, Anne, for those really helpful insights. So we're having even more questions rolling in, but what I suggest is maybe we can come back to you when we throw the floor open for further discussion.